All right, good afternoon. I'm impressed. I'm saying afternoon because it's 11 o'clock now, and I know for some of the room you're probably still on morning time, but we'll go with where we're at, right? I'm impressed. We got a full room and almost everybody's seated, and it's right on time. We only have an hour, so we're going to get started. For those of you who've seen me present before, I generally like to know who's in the room, but that would take most of our time, so we'll bypass that this time. I am Denise Pecca. I'm the Director of Programs at CityMatCH, and Jessica Ule is also from CityMatCH. She's here to help moderate and keep time for us. I'm going to give a quick overview of a learning collaborative that we've been doing with locals that was funded by the Maternal Child Health Bureau, and I know we have our project officer and some other Bureau folks here. Kate, where'd you go? Oh, they're right in front of me. Kate, and did I see Ellen too? Ellen? Yeah, there we go. So we thank the Bureau for this opportunity to be able to help locals align with their states. And I know I'm talking to a room full of mostly state folks, so it's important then to realize that this was really an opportunity to help locals align with the states to address their AMCHP priorities. And we have 3 states represented in various ways. We've got Rhode Island, Kansas, and Utah. And Audrey represents the local level. And is Lynn in the room yet? Okay, we may have Lynn too to bring in the state perspective. So with that as kind of setting the stage, I'm going to give an overview and then turn it over to them for each of their perspectives. Okay. Did I go too fast? Yes. All right. I already said this is an AMCHP funded effort to provide training and facilitation to 3 cohorts consisting of 10 urban local health departments. Are most folks in the room familiar with collective impact? Some level? Okay. And I say that also knowing that a lot of you may be familiar with collective impact, and that doesn't mean necessarily what you've been part of or what you've heard of is actually collective impact. It's a nice title that people like to say that their work is. But this is a definition of collective impact. All right. When we work with the teams, we essentially, it is about making sure they understand these 5 conditions. The definition of insanity is doing the same thing and expecting different results, right? So collective impact is one way to look at doing your work differently and very intentionally, if you think through the phases and the pillars of collective impact. So the team spent a lot of time really getting set up to be able to do these. The common agenda, if you really look, you want diverse voices, and that's often where we get into that definition of insanity. What I always say to people is look around the room, and if you're meeting with the same people you're always meeting with, you probably need to bring some new people to the table. So again, this is about being very intentionally and thinking about who's missing from the table. And from a local perspective, one of the first things we figured out is locals, surprise, 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 states in the room, locals don't always know what your state priorities are. So trying to make sure that the locals know what the state priorities are, that they know where to find them, and that they actually know who their Title V director is, and make sure that we're facilitating communication so that they can make sure they're aligning their work with the priorities that have been identified. So we're working on a common agenda, shared measurements, again, and again, if we're working with the state, we're making sure that we're looking at what the performance measures are, and that they can help make sure that they're aligning with those. The mutually reinforcing activities, continuous communication, because as we know, this is evolving work and people are always coming in. So how do you make sure that you're not always going back and starting from scratch? And then the backbone support. What's important to know is if you're familiar with collective impact, it used to be backbone agency, and the field really now talks about backbone functions and support, because you can have multiple agencies that provide those roles. In our case, usually the health department has provided the support and the functions for most of those roles, but in some cases, it's actually been the state. There's almost backbones within backbones. So the state is providing some backbone function to the locals, but the locals providing some backbone support to the other partners at the table. So anyway, those are the conditions, and that's what we really spend the first year of the Learning Collaborative doing, is just really working through and being intentional about making sure these things are happening. So we kicked off the first cohort in January 2016. Who was in DC in January of 2016? Anybody remember what happened? Snowed, right, and snowed, and snowed. And we had our kickoff, we thought it was brilliant. We were gonna have our kickoff tied to AMCHP, and so that we could have Title V involvement and the feds, and we were like the only ones here. So that cohort bonded. We were stuck in the hotel for days. And from the evaluating, because we evaluate this, the evaluators were like, I don't think we can ever recreate this, so we may have to put a little asterisk by what cohort 1 does. Cohort 2 then we kicked off in January 2017. And then to make sure that cohort 3 had as much time as possible, we actually kicked them off in October. Plus we decided to avoid January for kickoff meetings. These are the teams that are in cohort 1. So for states that represent these places, if you don't know that they're involved, please see me. But these are the folks that are in cohort 1. And then cohort 2. And cohort 3. And like I said, cohort 3 is really just a few months into their work. All right, so these are some of the areas that they're working on. You know, there's a lot, infant mortality is addressed in lots of plans, so there's lots of places to connect within that work in infant mortality. Access to care for AMCHP populations, disparities with breastfeeding rates, the well woman visit, teen health, several categories within there, social emotional wellness, pregnancy-related depression, substance use during pregnancy, access to care with the homeless population, reduce health disparities, and then developmental screenings and care coordination. So that's some of the work that they're doing. Basically, the technical assistance we provide is we have a kickoff meeting, we bring the cohorts together, we do a lot of training around collective impact. We make sure we ask the teams when they come to kickoff meeting to bring some new partners. So it's often some of that storming and norming happens around the table because it's the first time some of these folks have actually been face-to-face. So it's getting those relationships, and this is all unpaid work on top of everything else, right? So it's actually an opportunity to do some planning when you bring people face-to-face, as are these meetings. Then we have individual monthly TA calls with them, bi-monthly all-team webinars, either on the content or as they've identified challenges, and also opportunities for them to share what they're doing. As we've progressed through this, we've paired them up. So we have cohorts 1 and cohort 2 paired up so they can benefit from the work that's gone ahead, and then we'll start to engage cohort 3 into those pairings. But it changes the work, and we know people are generally also kind of competitive. There was some conversation just around here, like, where are we with the other cohorts? That's very universal, and there's actually that kind of opportunity to make sure that you are doing the work if you're sharing with others and you get to learn from others who are struggling in the same area. Okay, this is the work that's, like I said, they already are supposed to accomplish in the first 12 months, developing their common agenda, coordinating the activities among partners, and developing their structures and their processes. That all sounds easy, but we know in reality that that doesn't happen overnight. And then we work with the University of Kansas and their community checkbox. Teams record all that they're doing, so all that process stuff is recorded. And KU has worked with us on developing some really cool metrics to be able to capture that process stuff that's happening with the teams. All right, that was my quick overview, and I did it within time. So I'm going to turn it over to Rachel, who's going to talk about what that looks like actually locally, and we'll stop hearing from me.
Okay, good afternoon. I'm glad to be here representing Kansas and the city of Wichita, which is part of cohort 3. Wichita is our most populated city in Kansas, and they have about 7,300 births a year, just to give you a little bit of context about the city. Denise asked me to briefly, within 10 minutes, speak about the Kansas approach, and in particular, I want to share with you how we work intentionally and strategically to align the state and local initiatives specifically related to the Title V priorities and state action plan. So for those of you that don't know, sorry I didn't introduce myself. So I am the Title V director for Kansas, and so I do represent the state perspective, and we'll work very hard to represent the city of Wichita as far as where they're at in their work. So just to begin, a little bit of context about Kansas, like I said, to set the stage. I'm going to talk about our process, which when you look at the state process through the next few slides, understand that Wichita, Kansas, and Sedgwick County is one of our current MCH grantees. So they would fall into this model or framework and approach. So we receive about $4.5 million annually for the Title V block grant. We put in our state match of about $3.5 million, then in our locals, as part of their agreements with us, have to provide 40% match to the amount of money that they receive from the state health department. So together we're over $12.5 million in partnership. So I wanted to share this just to show that we have a continuous ongoing process when it comes to communication, support with our locals. So it's very much two-way. We're involved at all times, and we actually have I would say a competitive, definitely funding process that occurs on an annual basis as part of the agency timeline for what we call aid to local. So in January, which was just recently last month, our applications were released for funding. And the Kansas team is sitting over here. You can kind of raise your hand. So, Carrie, yeah, those are the folks that actually work really hard every year to evaluate anything that's changed within the Title V framework, block grant guidance, and sort of where we're at as far as our vision and progress for Kansas. And that application looks different every year. It could turn over, our guidance turns over, our service manual changes. So it's a very evolving process annually, and the locals have to stay on top of that if they want to apply for maternal and child health funds. We review applications and recommend awards between March and June every year. That is an intense process when we have the capacity. Several years ago, we worked as a team to completely change the way that we review applications. We have taken the application and is really framed around Title V, so our local applicants have to choose priorities, objectives, and measures that they are going to work on. There's really no way around it. The application is aligned that way with the state action plan. Then down here, July to June, that's our state fiscal year, and so I just wanted to be sure and emphasize that we work on the applications in the fall, they're released in January, we're reviewing, and then we're turning right around reviewing progress reports from the previous state fiscal year and the current one that we're just awarding or starting. That includes narrative progress reports from our locals and data, most importantly, I'd say, to see how they're doing. And it's not just a compliance perspective. We have really tried to shift first in our language and our mindset over the past few years around compliance to action and impact. So how can we assist you in helping us advance Title V priorities and improving outcomes? So here are more details around our process, and I actually have a couple handouts, and one of them is several pages of the websites where you can find our processes and our tools and our resources if anyone is interested in looking at how we do this. Even taking a look at our application, most everything is online. Our data systems and all the elements we collect from locals are online too. Well, so how have we made this happen? So we've thought very comprehensively about this. It's not just once a year we have locals apply, like the city of Wichita or Sedgwick County. We start all this as far as our comprehensive needs assessment. So we have public health regional meetings every quarter with our local health departments and our partners, and that includes some administrators across the state. We do this capacity-wise by and through an agreement and support to our local public health program, and they travel around to the 6 regions of Kansas. It's not a quick trip out across the state. It's like 5 to 6 hours to get to one of the points to meet. So potentially you've got 3 days wrapped up into a meeting. So we do it that way. We collect input throughout the year. We provide technical assistance and ongoing consultation to the locals and take their input as we assess what their needs are. I think what's really important too, and this came out in our process for our public health accreditation as a state health department, we align our state Title V plan and priorities with our state health assessment and health improvement plan, just to see where those linkage areas are. And we encourage the locals to do the same. So Wichita, Kansas, when they're applying for funding every year, we want them to think about their community health needs assessments and what their priorities are, how that aligns with the state, and Title V in particular, and then focus in around those areas. When we award the funds, we have external reviewers and members of our state council look at those applications, as well as our staff. There's criteria that we score and rate. We look at their partnerships, how they're thinking about sustainability. Collective impact is a framework. Are they continuously looking at quality improvement? Are they engaging families and consumers? So all of those things go into awards. Again, just real briefly, I'll just highlight a couple things on the slides, and you can take a look at how the process has evolved over the years. I myself conducted a webinar in the spring on the state action plan. I hope to do that every year. We not only share the plan with all of our grantees in our network, but we talk about how they can operationalize these things in their clinics, in their settings, whether it's direct care or enabling service or whatever it might be. Most proud, I think, over the past few years is the Kansas Special Healthcare Needs Director, Heather Smith, and I work to integrate the special healthcare needs application and process into the maternal and child health process. So Carrie and the team in Kansas does a lot of work every year, Casey as well, on taking in those applications that are sort of joint information and content and awarding as a whole. We used to have locals that would apply for MCH and apply for special healthcare needs, and it's like, no, we need this integrated and tied in. So it's all together now. We've increased our satellite offices for special health care needs, I think, from 6 to 14 in just a couple years by raising awareness around that. We have a shared measurement system. I think you'll start to see some of the conditions of collective impact when you see some of these things. We're able to evaluate the data at the state level and give it back to the locals. We've also aligned all of our home visiting and affiliated programs at the state level, because there could be a Wichita, Kansas, or other local health department or partner that applies for multiple projects or funding from Kansas. And so we really request from them to show us how they're complementing and supporting each other and not duplicating, and that they all play a unique role in service delivery. So this slide's important as I get into more of the Wichita-specific collaborative, and I think they're early in their game, Denise says. I've been on several of their calls representing Title V and thinking about how we can support them. I think the recent call was most productive because they're really starting to organize now around their project and choosing their priority and alignment area with Title V. So some of their gaps or potential needs and how we can support them with existing infrastructure and resources really came out of the last call. So in Wichita, I believe the direction they're going is aligned with our women and maternal health domain in the Title V action plan. The priority is coordinated comprehensive services across the lifespan. In particular, we are working on NPM 1, the well woman visit. But where they are really aligned is with our state performance measure for preterm births. It's also an outcome measure for Title V, so I've highlighted that there. We started work around 17P related to pre and early term birth clear back in 2014 and 15. We were very active in the state infant mortality COIN process, and if it, without that COIN work and that platform to really become structured and focused and organized, we wouldn't be where we are today in Kansas around progesterone. So because we've done a lot of work since the COIN, and in particular we had a pilot in Wichita, I've been talking with that team about building upon that. Here's just a look at our goals and our strategies related to progesterone. So how do we want to assist with the Wichita CILC team? What came up on the call recently is they're not so sure that some of their newer partners and their coalition at the community level are very familiar with collective impact. We can support them in training there. Quality improvement processes and strategies, documentation, collecting data. We have the means to do that and support them. I think additional resources after talking with Candace and the team there that came out is they certainly need some help in being more strategic. We've sent them quite a bit of evidence around utilization of progesterone when appropriate for women with a history of prior preterm birth. We have promotional and educational materials already printed that we can help them with that. They don't have to start over. They don't have to pay for those. If they do need additional money outside of their Title V grant that they receive, I told them we're open to supporting them in that around some innovative practice and changes. Definitely technical assistance and support from our epidemiologist is there at all times. And connection to other partners. I think Denise mentioned the teams at the local level. So right now, it seems like they have some of the same people involved, but are just starting to think about who else needs to be at the table. We have a partnership with Optum at the national level. They have an agreement with all 3 of our managed care organizations in Kansas to provide a very comprehensive OB home care, high-risk pregnancy management service to women at no cost. And all the providers have to do is if they screen them for prior preterm birth or they have concerns around the pregnancy, they literally just refer to Optum. And Wichita is one of the 2 service areas in the state. Only Wichita and Kansas City fall under this service for Medicaid-covered pregnant women. So that is huge as far as infrastructure that already exists that they can build upon. We also have a strong partnership with ACOG and plan to get them connected there. Of course, vital statistics is at the state level, and we can do a lot there. There's also a lot of providers in Wichita. We not only fund local health departments, but we work very closely with family physicians, obstetricians, and hospitals, including the medical center, the University of Kansas Medical Center down there. So lots of connections. They already have great partnerships in place, but I think we can assist taking that to the next level. The next 2 slides are just a couple screenshots. Did I miss my 2-minute? Oh, I did? Okay. Denise said I'm good. Okay. So just examples of, we had a pilot on 17P in Wichita with a really large women's clinic. And then we have some data that we've presented in form around state utilization and sort of what our goals are and where we're at now. So this red line and over here, that's room to grow and that's opportunity. So we want to work with them on that. Examples of some of the tri-branded materials already available. High quality and printed for Kansas that apply to the Wichita area. We have provider information on utilization of 17P as well as patient materials we're creating. Just kidding, we're not having discussions and questions right now, but at the end we will. And here's some information as I transition to Deborah for Heather and I if you need information.
And I'm going to say what Rachel was too kind to say. There had been some turnover in Wichita, so actually they were not aware of all this that was happening or that they were a pilot site during this. So it was because of having that connection and having Rachel on the call, and she's like, are you aware that then the magic happens? But this is why, that communication is so important, because you think that information is coming out and that people are getting it, but people leave and that isn't always shared. All right, turn it over to Deborah.
Okay, so I don't have slides. My name is Deb Garneau, and I'm with the Rhode Island Department of Health. I'm the MCH director, and our maternal and child health program in Rhode Island sits within our Health Equity Institute, and as you'll hear from some of the work that we've done, there's a big connection there. So in Rhode Island, we were thrilled to be part of this project. As you noticed as they went through the cohorts, ours is the one that is not with a city, and so it is the state health department. We don't have local health departments, and so that is why we were able to sneak into this opportunity. We found a great connection between the work of collective impact and then some of what we were trying to do within our health equity work within our state, and so and really, made the case that we can benefit from this technical assistance in this real focused area. So. Because we have no local health departments, we rely on collaboratives and community contracts. And several years ago, we looked at our data that we were receiving back, our large goals and our initiatives. We had a new health director that came in, Dr. Nicole Alexander-Scott, who has been wonderful. And we were able to, take a step back and say, are we meeting what we should be meeting? Are we achieving the goals in our particular areas? And what we came upon is that we really needed to do our work differently in order to maximize our outcomes and to coordinate our work better. And so this collective impact framework and the tools and the opportunities that were provided for us helped us really as an internal department to, get together with our different areas and approach and address our work in a whole different manner. So we had chronic disease folks who, even were split up among their own team, that each person and each program would really focus on a different organ and, not necessarily the whole person. We, from the health equity perspective, we're saying, no, we need to focus on the whole community, not even just the single person. And so how can we, really do this work and implement our programs in a different mindset. So we started a health equity zone initiative that meant we were collaboratively funding our communities to address some of the health barriers that they had within their community. And so some of that, looked at their social determinants of health and their access to food and their overabundance of liquor stores or just small markets where they didn't have fresh fruits and vegetables. And we looked at lots of different areas for recreation and looking at the safety of the recreation that was available. And so those are, ways that we connected with our community more collaboratively and asked them to even look differently. And so within the health equity zones, what we were funding is a backbone agency and then a group of collaborative partners. And they came from planning and housing and transportation and, their healthcare providers within that community. And as a group, asking them to address and to impact their community in a different format and in a different way. So it required a lot of change at the state level within our department level because we had funds that were specifically addressing diabetes and we had funds that were addressing maternal and child health and we had breastfeeding initiatives and funds that were, in particular areas. And we as a group had to collectively agree on what we were going to interact with and what we were going to fund. There were a lot of growing pains when we first started to go through this. In fact, I received a couple of reprimands about making changes to staff and, just kind of like operating on my own as though, MCH is sometimes accustomed to doing is saying, oh, I have my staff and I'll, change this initiative. And as we were really looking at the impacts of, me changing like a breastfeeding connection and contact and what kind of impact does that have on the diabetes program and how they're implementing their perspective, their programs within that community as well. So we had to form this management team within the department, and we all have equal voice within that team, and it's composed of the maternal and child health program, health equity, chronic disease, and we have also a health promotion center, which includes tobacco and physical activity and injury prevention. And so all of us kind of connect and meet and make decisions on the program management together. It sounds like it would be easy, but it's not. And, it required a lot of us really advocating the areas that we were so focused on to, for the greater good and what was going to give us the best outcomes in that particular community. So one major area that we made changes at is in our internal structure of how we implement programs. Another major area is how we actually implement the programs at the local level, and we relied on a project officer to be that communicator for the particular initiative. And so, I had to sit with that person so they could understand as much as possible of maternal and child health and how, they're going to relay those messages. And definitely the experts back at the office are available to, provide different examples or targeted technical assistance, but we needed to really empower that role of a project officer and being that link and the liaison for us. And the last major area that we focused on and made lots of changes in is in the data. So we, every program has indicators that they're focused on within their particular area. We're all familiar with the maternal and child health indicators, and the chronic disease indicators had to measure the number of people that were participating in pre-diabetes classes and diabetes classes, and those that participated, those that completed, and they had very clear indicators that they were working on too. And so we as a group came together about measurement and measurement tools, but we also took a step back and looked at the social determinants within the community and really looked at the other types of measures. We developed a community health assessment group that was composed of folks from the community through the health equity zones, and then also we have a great relationship with the Brown University and the School of Public Health and Epidemiology and connecting with us on the work that we're doing as well, and helping us form the foundation, the framework for how we were going to evaluate, and then of course the health department epidemiologist. So this opportunity has really helped us to solidify our work at the management level in infrastructure, at the programmatic implementation area, and then also on the evaluation and looking at the outcomes. So we are still in the process of working through our project, but I am happy to report that our year 4 funding is becoming available for our health equity zones as of April 1st. And as we as a management team were working on our processes for that, there was a lot less fighting, and there was a real understanding of collectively how we, are making our decisions within MCH, for instance, we're impacting the other areas. So if that can be a barometer for us on how we're really changing how we do our work, and that could be one of our indicators. And then I had also mentioned about the CHAG group, the Community Health Assessment Group, and that's one of our other longer-standing activities that will continue. So thank you. Yeah, I can provide the link to the website and the materials that were developed. We also were featured in the City Lights CityMatCH article that also has links there. Thanks.
Thank you. And now we have Audrey coming.
Well, good morning or good afternoon, wherever you're from. So Denise already asked this question, but I want to ask you a probing question. How many of you feel completely competent at doing collective impact? Show of hands. How many know absolutely everything about it? Okay, so this is where Salt Lake and Utah were 3 or 4 or even 5 years ago. So to give you a little bit of the background of what happened with our collective impact, our county government was looking into pay for success different programs across the state. So we had third sector and we had some other independent funders that were looking at some of the projects that we had within our county that we maybe could leverage some funding for, home visiting and several other MCH programs. Well, we were 2 years into this project when there was a call for applications for individuals to participate in a collective impact through CityMatCH. I am really fortunate that I am a member representative to CityMatCH from the state of Utah. And for those of you who don't know the composition of Utah, besides having lots of Mormons and polygamists, we have lots of urban areas, we have lots of rural areas, and we have a lot of frontier areas. And so my wonderful MCH director, Lynn Nilsson, really has a challenge in trying to coordinate the MCH activities across such a diverse state, because the needs of each community might be very, very different. So when we started the Collective Impact Project 3 years ago, we were really fortunate because we thought we had a bit of an understanding of what collective impact was, but we found out we really didn't. And one of the first charges that Collective Impact through CityMatCH gave us was look to non-traditional partners. We don't want to have the same people from the state and from the local health departments. We want you to bring in the community partners. And those are the people we want you to bring to our kickoff meeting. And so we brought a human services director who had worked with Families First for many years and the Voices of Children. So she was a wonderful community advocate. We also brought in the director of our community health centers. And so these were partnerships we hadn't previously looked to for trying to do the MCH work within our community. And so we went to the Stormageddon year, and it was a wonderful opportunity for us to have discussions with those non-traditional partners and to talk about who else is going to be available within the community to help us around this issue that we had identified. Our initial issue has changed over the last 3 years. So what we thought was the primary objective for our community, which was teen pregnancy prevention, has evolved over time. Now, during that 3-year period of time, we've had changes at our state health department leadership. We've had changes within our own health department in terms of our individuals that were the project coordinators for this effort. And so CityMatCH was really instrumental in helping us throughout that process to really get over those bumps and those problems that we had in trying to re-engage a community to look at a different project. Now, I like to tell you a little bit about our state health department director, and many of you probably know Lynn. Lynn is not very shy, and I like that about her. She is very much a go-getter. And when she looked at the MCH priorities about 3 years ago, about the time that she took over her position, what she did is she did a bottom-up and a top-down approach to looking at the MCH priorities for the community. So it wasn't just health department folks in that room. She had a very comprehensive cross-section of all of the MCH providers within the community. And we spent a long afternoon and a couple of different times having focus group discussions about what really mattered for our community. And then what she was able to do is she was able to take that to our nursing directors, so this is local nursing directors across the state, and what she was able to do at that point is she was able to talk about what are those areas that we have in common and how can we set objectives around those. Because most of us have experienced some real cuts in resources and availability of funding to do the work that we do. And the work is no less important than it ever was, but the funding that is behind it has waxed and waned. And so what the state has really done for each of our communities around collective impact is to look at the resources that we already have available. So with regard to our specific collective impact, what we did is we went to Lynn's staff that were working with teen pregnancy prevention, and they were part of the group, and they also brought other partnerships and funding into that effort. Now, most of the work that we do in MCH doesn't have a real strong funding source, right? And so it's really important that we not duplicate effort in any of our communities. So my comment would be the importance of the state local partnerships in being able to leverage those resources, leverage those partnerships to be able to do the work more comprehensively. Did you have any comments?
No, just, you know,
I'm a contraband member of the channel.
I'm really, really fortunate to have such a supportive MCH director, and we've really enjoyed in Utah. You know, prior to Lynn Nielsen, many of you knew Nan Streeter, and we have just really enjoyed a lot of support and really clear direction in where we're going with regard to MCH, because some of our communities really don't have the resources that we have in more of the urban areas. And so there's really been a concerted effort by the State Health Department to try to find those resources needed by those communities. So with that, I'll end my comments.
Well, actually, we'll say a few things. Okay, so just a big, you can say with me. I'm really quick. So I guess the whole, you know, and the three of us were talking about this on the phone earlier in the week, is that regardless of the efforts, regardless of the funding, regardless of all of the things that come at us all the time, it's about being in communication with your people, right? So Audrey is one of the nursing directors for the largest city and county in the state of Utah, and Audrey and I have been friends for many, many years, way before I took on this role, and we're in communication on a regular basis. So regardless of what project has going on, regardless of the big picture things that I'm accountable for as being the Title V director, it's about being in communication with those people and figuring out how we weave together and how we don't weave together and getting ideas from each other. So that's my takeaway message, is just keep those communications going, because as we are making a difference for women and children, that's really what it's about, is working collectively together for those big picture, to have those big picture impacts for populations.
All right, thank you, ladies. Can we give them a hand? Okay, we actually stayed on time. This is impressive. So we allow time for questions. This is being recorded, and if you haven't figured that out, so Jessica has a mic. So if you have questions, please raise your hand and wait till we get the mic to you before you ask it.
Thank you so much for your presentation. I really appreciate actually hearing the connection between state and local. And so my question is sort of a three-parter, and I'd love to hear from all three of the Title V directors on the panel. I'm wondering, and as always, there's never a right or wrong answer to this, but I'm wondering for your three states whether you have talked about this work in your block grant application, and then related to that, whether it's connected to your state action plan and or your national performance measures that you're working on.
Yeah, I can start. Yes, our block grant application under cross-cutting and under life course area is where we discussed most of the collective impact work that we are doing. Hearing the new guidance, and we'll need to find a better place within our domain areas to reflect this within our block grant. And yes.
I actually think it would still be in cross-cutting.
Okay, yeah.
But that would be
Right. All right. So yeah, we definitely want it to be a little more pronounced than the cross-cutting life course, seemed to be almost an add-on sections to the block grant in the past. And so how we can integrate it into our domain areas is something that we're going to seek after to do as well.
Okay, for Kansas, I shared a slide that showed the alignment there. It falls under our women maternal domain, specifically NPM 1 and an SPM for Kansas, which is preterm birth, and an outcome measure for Title V. Wichita is part of cohort 3, so they didn't start until fall of 2017, so it will be in our block grant application. We'll talk about it. I think what's really exciting, to Denise's point, is Wichita, some of their leadership had turned over, and so they missed some of that on the ground work and activity as part of our IMCHP partnership with Wichita. So if it weren't for this collaborative, I don't think it would have resonated the same, or we would have elevated to this level of conversation with them. We're in conversation all the time. But after the last CityMatCH call with that team, I sent my lead running the 17P work to Wichita and just sit down and have a meeting with them and get them up to speed. Thought it was really important versus us just being in Topeka and trying to assist with the sharing of resources. So yeah, we'll continue with them and certainly write about it.
I bet Lynn is so happy she came up here now.
So once again, as a Title V director, I have to keep like the big view of the state, right? And the answer is yes, because, as Audrey said, her collective impact efforts have changed. They're now really focusing on adolescent health. And it would behoove me, see the way Utah's cross-cutting sections are set up, I would say no, but we have an opportunity to kind of change things, and I'm very cognizant of adolescent health and the impact of adolescent health, and so it would behoove me to highlight what Salt Lake County is doing. So yeah, in the block grant.
This is questions for Rhode Island, but anyone else can answer. You talked a lot about the role that you all are playing in the shared measurement and what you're collecting there. And you talked about your MCH measures, you talked about your chronic disease measures, and I just wanted to hear more about what you are measuring in terms of that like health equity, social determinants of health piece of it.
Okay, so we have a list of 26 indicators that we think impact or measure health equity. And we are starting with 5 that we can look at across domains, but they are concerning housing and education and transportation, physical activity, and access to parks and food access. So we have drilled down a lot of indicators. We started with over 1,000 and kept drilling down. And what we're hoping to do is to highlight for communities what these indicators, what their data looks like for these indicators. And we are in the process right now of seeing if we want to tie that directly to health outcomes, and or if we can, just provide the information for housing, for instance. What is the affordability of housing within your community, or those kinds of indicators, and as opposed to tying it directly to the population health goal around the incidence of diabetes or whatever it might be that that we can provide in that particular area. So it's definitely a work in progress, but we do have a list of indicators that we're working on.
What you're doing is instead of to say maybe in housing there's a maybe HUD has some measure of what affordable looks like, and then trying to get those communities to get there and not tying it back, like you were saying, to the
Right. So because this work is generating from the health department, all we wanted to measure, not me, but others, all they wanted to measure was the incidence of diabetes or the life expectancy in a particular area, although I think that's a great health outcome area. But there are, others that they just wanted to measure, like how many minutes of physical activity do education, does each community offer, or how active is the school health curriculum and providing. So they wanted to measure these real detailed health indicators, and this is where we keep stepping back and saying, no, let's look, collaboratively, and let's look from a different lens at the community indicators, and, kind of charting out that logic model that will look at, these indicators and then their impact on particular areas. So it's somewhat of a struggle internally to try to, we've had struggles along the way with each piece of this. One is how we're going to manage it, then another is how we're going to implement it, and then the data piece is also a struggle of, what we're going to look at to measure the equity or the collective impact of health equity within that group.
community.
Other questions? I thought I saw another hand go up when, no. No other questions for anybody? All right. I just want to echo, I think, what everybody has said at the panel, that don't assume just because it's on a website or you think you have processes in place that stuff's getting to the locals, but maybe actually pick up the phone, have a meeting. And we encourage that at the local level. You know, I'm with an organization that's who we represent, but we're always telling them that that's important and they need to do that. Because the magic happens that way. Otherwise, you don't know. And seriously, if Rachel hadn't been on the call that day, they were on the right track, but they didn't know all these resources that were available and that could really elevate their work. So thank you all for being here, and have a good rest of your day. Thanks.